So, hello everybody to today's session of the Virtual Global Spine Conference. This is Alexander Mameghani speaking from Switzerland, and we have our hosts and co-hosts and panelists here online too. I see Michael Galgano and Jonathan Rasuli, and today it's about tumor, and I was attending the German Society of Spine Surgery today, and there were tumor sessions today as well, and it was really nice to see that worldwide the cases are treated very similar. The techniques are very similar, and I want to show some cases. And there's something new today from the conference. I have some polls, and I want everybody to use additionally the smartphone, because I will present a QR code and you can scan it. It's completely anonymous. You will not forced to give any data, but you can log in and then I can ask questions and you can poll it, but you can also use the chat box as always. If you have questions, if you have something to mention, this is an interactive conference, and we love to hear from you what you think about our cases. I have nothing to disclose for this session, and I will just start with an opening question, because I want to know, in the audience, there are so many spine surgeons. Are you familiar with tumor spine surgery? So this is the QR code. I want you just take a smartphone and capture it, and you will be able to go to a website. This is really easy. The password is tumor, because today it's about tumor, and you only have to enter the password once, and then you will see this presentation. And whenever I ask you to look into the smartphone, you can answer the question in a poll. So the first question I have is, are you familiar with tumor spine surgery? How many surgery cases do you do per year? Are you a very experienced tumor surgeon? Do you do more than 20 a year, or like 1 or 2 a month, 6 to 20 per year, or only occasionally? Or are you in a degen or deformity center and you don't do any tumor spine surgery? So when you now look to your smartphone screen, within some seconds there you will see the questions. Right now you can answer, and I see it works. Some answers are coming in. And this is just an opening question, whether you are familiar with tumor spine surgery or not. So I can learn a little bit how experienced the audience is. So I go on now, and these are the results. The majority is very experienced, like more than 40, more than 20 a year, and some are occasionally tumor surgeons. And we have a part of our audience that is not familiar with tumor spine surgery at the moment, maybe perhaps in the past, maybe in the future if you're a resident. So I will start with the first case. It's a 62-year-old male retired worker, and he was suffering from progedian pain, and he waited very long. And finally, he was admitted to the emergency room in a really bad condition. He was not eating, he lost weight. And in the lab, we found a severe hypercalcemia and acute renal failure. It was obvious that the patient has a bone disease, osteolytic bone disease. And from the neurological deficits, he was quite able to walk. He had no paresis, but there were these painful electric sensations through the body, below the neck. And this was the CAT scan that was performed in the emergency room. And does anybody want to take over and comment what he is seeing here on this CAT scan? So I can count, this is T3 and T4. There's a destruction of two vertebral bodies in the upper thoracic area. The cervical spine is okay, and you can see many changes in the thoracic and lumbar spine. The bone quality is not good. You see from the soft tissue maybe that this is a thin patient. He is cachectic. He is not really strong. He has only little muscles, and the MRI shows this. This is the thoracic MRI. C3, C4 is destructed. You see very inhomogeneous vertebral bodies in the rest of the thoracic spine. Another fracture down there at T10, and this is the cervical spine. And you can easily see that, oh, Wendy, you're here. I can see you. This patient has got a malignant disease. Does anybody want to take over and just say what kind of tumor this could be? It's a very classic one.
Do I get you? I already answered in the chat box, and then I thought maybe I ruined it.
Okay, no, it's brilliant. It's brilliant.
I think because it's diffused throughout the spine, and on the MRI, you showed us a speckled pattern that's in all vertebral bodies, older patients. So I'm going to guess myeloma. Yeah, it's brilliant. I don't know whether you've seen the first slide, hypercalcemia, renal failure. He has a huge amount of proteins, so it was clear from the beginning that this patient has a multiple myeloma. We didn't do any biopsy. The bad condition, pleural effusions, he was really bad. What will you do? He is not paraplegic. He has only these sensations, and this is the new tool. Everybody can take a smartphone and capture this QR code, and the password for this is Tumor. You only have to enter it once. I will repeat now what I've said 2 minutes ago, but this is a new tool, and now you can see in 1 or 2 seconds 4 options. What would you recommend? Would you recommend a decompression only, a decompression and stabilization with screws and rods? Or would you do additional support of the anterior column? Would you add some corpectomy and cage from the back? Or would you just go cautiously and put the patient in bed rest, start with chemotherapy to ameliorate the bad condition, and try to fix the spine later? There is no need for a rush. He is able to move the legs. What do you think? Just feel free to answer. I can go back if you want to the QR code. Just put it in the chat box. When a panelist or a host wants to take over, what he would recommend, just feel free to step in. Otherwise, I will ask Wendy, what will you do if you were a surgeon like me? If I was a surgeon, I think you had quite a bit of deformity there. It looks like the retropulsion was osseous, so I think you need to decompress it because chemotherapy is not going to help any bone in the canal. And then it seemed like there was, I would have to see it again, but with that deformity, I put corpectomy, and I think you said cage placement. I don't have it on my screen anymore, but I think that was choice 3. It seems like a lot. I'm pretty conservative. Normally I wouldn't do that much, but for this person, I might.
You know, everybody can learn surgery. It's about the indication. This is a hard time, Wendy. Brilliant. So these are the results. Not everybody has voted, but you see there are really cautious people in the audience. And this is what I did in the beginning, because the patient was so bad, and the anesthesia said, with these electrolytes, with these natrium, with this calcium, we don't want to put him into narcosis. And so he went to the oncology, to the internal medicine, and they did a fantastic job. And within 1 week, he was in a really good condition. And then I did the SIN score for control that I'm not doing an unnecessary surgery. Just for a count, this is 1 because it's the semi-rigid spine is T3, T4 would be different if it was 2 vertebrae higher. It is a pain relief in recumbency, very obvious. He was so bad, he was so in pain, but in recumbency it was good. The bone lesion is obviously lytic, and we can discuss a lot about the radiographic spinal alignment. Obviously, there's a kyphosis. That would mean 2 points. But if you look at the facet joints, subluxation is really relative. You can give 4 as well, but I have given 2. The vertebral collapse, quite obviously, is more than 50%. No discussion, please. And there was 1 facet and pedicle involved. And so we have a SIN score from 15. If you're not aggressive in giving points, you will end up in 13. So very clear, this is unstable spine when you just what you told us. And this is what I did. I did it from posterior. I first put in the screws, 2 above, 2 below, and then I augmented them with cement. And you can see the cement is not staying only in the vertebral body. There's some leakage into the veins. You can see it in the upper here on this slide. And it's hard to augment T1 because of the shoulders. There's always a bad side, and you have to magnify. You have to play with the intra-op fluoroscopy, but it's really helpful to augment these vertebrae in a multiple myeloma because the bone quality is so bad. And after I put in the screws, I put in the rods. And so in the rods, and you can see the kyphosis, the hyperkyphosis was restored, and now the alignment is not too bad. What to do now? Usually you can take a cage, but this is 2 level corpectomy from posterior. That means you have to take a small cage, and the bone is bad, it's weak, it's osteomalacia. And so I checked with a Penfield dissector where are the borders. I could see them because the pedicle was missing. And then I took a gauge and I inserted cement as well here. Interdigitation is crucial here, and it's I'm able to put in cement, and then I take several instruments, soft instruments, and I'm a sculptor, and I put in the cement step by step. I always take out the instrument for the next shot, X-ray shot, so you don't see the instrument. But finally, I'm able to augment 2 lytic, completely destroyed vertebra with cement. And in the CAT scan post-op, you can see there's a pretty nice construct and a restored alignment. And I don't fear of a migration of the cement because the interdigitation is so good. And this lets me this is a strong, solid construct, and I don't have to take a cage. So this is the standing post-op X-ray. The first X-ray, I don't have a pre-op one, and this is 10 months later. You can see some slight kyphosis, but not in the construct. It's below. It's where the other thoracic vertebrae are collapsed a little bit, but the patient was fine. He received chemotherapy and radiation, and he was doing well. So this is what I always leave. I leave the rods a little bit longer so you can connect, if necessary, in another surgery, this construct to another one. You can lengthen it without opening the complete wound.
Hey, Alex, this is Mike. I think that's a fantastic result. That's an awesome case. I would have done exactly the same thing. You know, the issue with doing a 2-level VCR here is that you have to obviously clear 2 complete vertebral bodies out. You have to clear 3 disc spaces out. You have to get a cage to sit on these cruddy end plates. So I think you did everything perfect here. I think it's a fantastic result.
Thank you. Yeah, this is a remnant of my cement talk, and I'm happy to present this now. So the next case is a 76-year-old female patient, and I'm so glad that Wendy is here because this patient knew that she had cancer, and she knew that she had spinal metastasis, and the radiotherapy was planned the next Monday, which means 2 days later, the radiotherapy should have been performed or planned. But on Saturday, 2 days before, she suddenly became incomplete paraplegic, and we received the call in the afternoon 2 days before start of radiotherapy. And this is the CAT scan we have seen in the ER. And we see this lytic tumor. I've shown this on social media before, and this tumor is destroying the pedicles, the spinal process, and this is the MRI. First, you can see the steer or TIRM sequence on the left. You can see the T1 without contrast on the right, and here T2 sag and another T2 sag. You can see the compression of the spinal cord, and this is the actual view. A huge tumor mass surrounding the myelin posteriorly, a little bit via the left pedicle into the vertebral body, and it's T10, T9. There's the spinal cord compression, and I don't want to tell what kind of tumor this is because you can make a guess. So this is intraspinal compression level T9. There's a slight white line inside the tumor mass. Wendy, can you tell me what is white in a mass in a T2? Is this fluid, isn't it?
Well, it's a regular T2, it can be fluid or it can be fat. I don't know if this is fat, but yeah, that also can be bright on T2.
Yeah, I will show a final one, and maybe it's so hard online with only several sequences to give a good diagnosis. But you can tell something about necrosis. Do you see a necrosis here? Do you see something like a adenoma, like cystic structures, or what is your suggestion if you see this contrast enhanced T1 on the left side?
So, so I think, I don't know what you said about cystic structures or adenomas. I don't know what that meant, but so it's very homogeneous.
Like a colorectal tumor, which produces some mucous tissue and fluids inside. So I think this is a very heterogeneous, homogeneous contrast enhancement inside the tumor, and I will just go on. We see a paraspinal tumor localization as west. The chest is infiltrated too. So this is a really progredient tumor. And my question is, when shall we do the surgery? The patient is AZHC, it's incomplete paraplegic sub T10, and when would you perform surgery? Again, you can scan the QR code and only have to enter once the password tumor, because it's about tumors today, and then you can answer the question within the next seconds. When would you perform?
Give us a chance, Alex. It ended it before I got to push the button.
I ended it.
I was ready to put in my answer.
I will
Let's
do
try again.
just I restarted it. If you have the chance to answer again.
These polls are fun. That's why I want to make
Okay,
sure I
the
get a
polls are
chance to do them.
open. You can just enter the answer. Would you go straight into the OR after the MRI? Would you wait until the next morning with a delay from less than 12 hours? Or would you say, okay, no, I will have to do this embolization pre-op. I will wait and make it as soon as possible, but maybe it takes about 20 or 22 hours. Or do you think it's incomplete? I can control it, I can observe it, and can wait more than 24 hours. So this is my question. And I see maybe we have some answers in the chat box as well. Wendy, do you see on the screen something new? This is the MRI where the diagnosis can be made. Our radiologist told me.
These two images right here?
Yes, on the right side.
This isn't the one I answered online, is it, or on Twitter? Is it?
No,
okay, this is a different one.
On the right side.
So because you said that, I'm looking for the primary because you said it's metastatic, I think. You said it was metastatic. Something homogeneous and expansal like that could also, be again lymphoma, myeloma, something like that, but I don't think that's the case here. Plasmacytoma.
Yeah.
There might be something in the lower prevertebral soft tissue. I don't know. I don't see anything else in this picture.
Yeah, it's just 4 levels above. There is a lesion on the right side. It's T1 without contrast, and it's hyper. On the left side is with contrast. I don't know whether you can see it, whether the solution is good. But the radiologist told us very typical for malignant melanoma to have a T1 like this. You can nod or shake the head, but it is a malignant melanoma is known in this patient. She had metastasis known, and so she was here and paraplegic. And the results of the poll, I skipped it. So here are the results. The majority would go immediately straight into the OR. 25% would wait until the next morning. Anesthesia is not happy to start a case like this at midnight. We do some conferences at midnight, but not surgeries like this. Mike, I'm laughing. So this is the history. Unfortunately, if we have known that she had this kind of metastasis before and there was a CAT scan, we would have maybe performed prophylactic stabilization. Everybody hates prophylactic surgeries, but in this tumor destruction with this clinic, maybe it would have been a good idea to prevent the situation where she now was running into. And the back pain and the Zinn score, everything showed that posterior involvement, lytic situation, that it is an unstable spine. Now there was a slight fracture. You can see, and this fracture led to a little bit of hemorrhage intraspinal, and then she worsened from the neurology. We did decompression the next morning. We waited less than 12 hours, but we didn't want to start in the night where the team is not so well equipped. Everything is shortened in the night. This is my question: how do you go into the tumor? Do you go right through the tumor? Do you expect vessels coming like this, or do you expect vessels being like this in a homogeneous tumor where contrast goes everywhere, so blood can be everywhere? How will be your approach? Will you go
like the easiest way, in this case from the right side, just option 1, would you go straight in the middle to decompress the spinal cord? Would you go via 2, or will you go dissect the tumor, go to the major vessels on the left side, or would you go a far lateral approach? Or would you do something completely different and just put it into the chat box? Now, just try to vote. What is your strategy in spinal meds like this? The easiest way, straight through the middle into the spinal cord, dissect through the tumor, or would you go like, no matter, just piecemeal, bite by bite? I don't need a special strategy. Wendy, you may vote too. I see you haven't voted yet. So I usually go via 2 and 3. I will not go via lateral. Is the poll working? The poll is not working? Okay, again, what is your approach? It should start now. Otherwise, I will skip this poll. Maybe again, should be working now. I will wait some seconds so more answers come in. And many answers like this. Straight through the middle, dissect through the tumor. This was my strategy, and piecemeal. This is what I did in the beginning when I did the first, and my teacher was not there. Then I thought I can do here a resection in here, and it took very long. And today I go straight through the tumor, straight in the middle, and try to be as fast as possible. This is the post-op X-ray. You see 2 screws are pretty long, and this is why this vertebra didn't receive additional cement, and the decompression was like 2-level laminectomy. You can go 3 above, you can go 3 below. I think it is important that the construct is solid enough. What is the best to prevent major bleeding in tumor spine? There's always a bundle, and you know, today we have so good hemostats, and the bipolar cautery is so good today. We have tranexamide acid. We have a lot of experience by the anesthesia. I want you just tell me from these options, what is your major game changer? What is really the best benefit in tumor spine surgery? I have shown my one on Twitter, on social media a week ago, and now you can start voting. If you look at the smartphone, or Mike, you can use the chat box, of course. Mike Selby from Australia. I would love to hear what is the game changer for you. And you can select several options and send in the end. And it is clear that it will be maybe 1 or 2 things that are favorites of us surgeons. But in the end, tumor spine surgery is always a team approach, and with a bad anesthesia or an inexperienced surgeon, these surgeries can easily go into a disaster. So the audience was answering, and we see a peak in hemostats like Surgiflow, FlowSeal, whatever is available. These are the agents we can use in every surgery, deformity, even in degen. If you have a dural tear and there's a lot of epidural bleeding, these hemostats are really working nicely. I have this bipolar now. Michael Garganio have given me the hint from this brand, and it's now, because of the color, it's called Lamborghini in our hospital, and we can use 2 of them simultaneously, and this makes the surgery a lot easier. And maybe I'm biased now through this big difference to our non-stick bipolar cauteries we had before, but this is really a good one. So the next case is a little bit more complex because he is 50 years old and he has got a mechanical back pain in the lumbar spine. Also, he was suffering weight loss, and before the diagnosis was made, he was depressed. He had a burnout. Nobody knew why he was like this, and because of the back pain, finally the family doctor made a CAT scan of the lumbar spine. The blood sample was completely normal, and this was the lumbar spine. Back pain, the first thought we have is this, oh, this is a low back pain due to this osteochondrosis, but on the lateral we can see this tumor between T12 and L1. Again, on the left side we see T2, in the middle we see T1 contrast, and a coronal one on the right side. I've shown this case on Twitter as well. Everybody who remembers this case can now answer the question in the poll. What is the diagnosis? Now you can type in whatever the diagnosis is. Within the next second, there should pop up a field, and you can enter and type in what kind of tumor this is. I will be waiting a second because typing in takes more time. Wendy, you remember what you answered, didn't you? Okay, so let's have a look. What is the audience typing in? Maybe it's only one answer from, okay, it's renal cell. Yes, it is easy to see the right kidney if you take a look to the paravertebral tissue, that there's something going on. Without these tumor, Wendy, would you be able to judge this met, or is this just this indirect information?
Yeah, so, and on the other sagittal image that you showed on the first one, they had a lot of lymphadenopathy too in front of the spine. You had on that one picture, even though it didn't, yeah, the first picture, see all the lymph nodes in front of the spine? So we already knew it was going to be something metastatic, like not a primary bone tumor, like chondrosarcoma maybe. But other than that, you couldn't tell just from these images probably.
Yeah. So the metastatic renal cell cancer is a hard one, because if you have metastasis, the concept is palliative. The urologists say the patient will not benefit if we perform a tumor nephrectomy. And nobody is able to give any advice about life expectancy. So what is the first step? The oncologists, they made a tumor board, and they said he needs immunotherapy and radiation of this brain metastasis. And maybe this metastasis is the reason why he was going depressed. He was no hemiparesis, he was no seizures at all. He was just depressed, and was not the guy he was before. And a patient with brain metastasis, how long is the survival rate? Does anybody know in renal cell cancer plus brain metastasis, what is the life expectancy now? Because if you don't have these metastasis, I would say renal cell cancer. I have seen 5 to 7 years survival in my career, and everything is shorter with brain metastasis. So the pain was getting worse. 7 months later, he received immunotherapy. He received a radiation of the brain, of the head. So he was not able to walk because of the pain. He has slightly paresis of the left leg, but the pain was so hard for him. And again, back to the brain metastasis. This was the initial after radiotherapy, and now I will spoil. 19 months later, this is the MRI of the head again. The brain metastasis was not growing; it was under control. And the patient had a problem in the spine, and the metastasis here was growing. This is T12, this is L1, this is L2, and the tumor was really aggressive in the thoracolumbar junction from one posterior element situation or one segment up to 3 now. And you can see here in the corona view that the spinal canal is not involved heavily, and the actual view as well. The spinal cord compression is not there, it's not present. It's radicular compression on the left side, and it's easy to see that the patient has got a lot of pain when he is getting up because of the mechanical destruction on the left side. This is a mid-sagittal T2, and on the right side you see the renal cell carcinoma. This is different to the malignant melanoma with an urgent situation and in a paraplegic situation. This patient has got time. So what can we do now? And this is just a synopsis of the 4 images. And within this 7 months, some metastases didn't grow, some were shrinking a little bit, but the T12L2 met is fast growing. So we have no judgment what's about this tumor. Is this really a situation of the thoracolumbar junction? Is the tumor here very aggressive, or is the complete situation getting worse? So when the instability persists, we can jump through the SIN score, and we will receive 11 here because the collapse of the vertebral body is not present, and we don't have a kyphosis, we don't have a subluxation. So the SIN score is not too high, but we see this lytic situation, and the pain from the radicular compression is really strong. This is the Angio Cat Scan, and you can see the tumor here is highly vascularized. Usually you don't see mets like this so clearly, so there's a high amount of contrast in the vertebral body in the situation. And I just want to ask you, what is your recommendation? What shall we do now? Do you want to go to surgery, or would you go for conservative treatment? Will you try to make another radiation, another chemotherapy? Do you say, okay, I don't want to touch this patient in the OR, I will not help this patient by surgery? That makes no sense. Or will you say, no, I'm going into the OR, I can help the patient with a surgery, with a deep compression or stabilization? Okay, let's have a look. The poll is pretty tight, I think. We have 50-50. Some wouldn't touch this tumor patient, some will try to help him. So when you will do a surgery, what will you do? Will you do it minimal invasive, or will you do an embolization first and then do it minimal invasive, or would you try to debulk the patient, debulk the tumor and make an open stabilization from posterior? When you don't have embolization in your hospital because it's not available, please use number D. So RCC metastasis, these are beasts, highly vascularized. What would you do? Embolization plus MIS or only MIS, don't touch the tumor. What would be your favorite strategy? Just feel free to use the checkbox as well, because I know many patients will do the embolization first. I think for me, it's, I will show the results. Most would do a minimal invasive stabilization. I did an open one, and I will explain why I did this. The embolization is mandatory for me. Here you can see the first pictures of the catheter in the aorta, checking every segmental artery, T12, L1, L2 feeders were coming from every segment, unfortunately. This is the L2 artery, and you can see the blush. It's really highly vascularized, and embolization with coils and with other lipoidal substances are easily to be performed by a skilled neuroradiologist. So on the right side, you see only the segmental artery T12 before the embolization. On the left side, you see after. The blush is a lot less than before, and I took the patient on the same day into the OR. You can see this is 11:50. This is just like noon, and it's really hard to combine embolization with surgery in a hospital, in a public hospital, because the radiologist, the anesthesia, the OR room, the surgeon, everybody has to be there on that day, and it's really a concert. And when it's working, it's nice. So I did this open surgery, and I debulked the tumor. And I explain why I did this. I put in screws, but not on the left side in these tubes. I used cross connectors. And this is the CAT scan, the construct. You can see the lytic or debulked situation on the left side. You can see one coil, still one coil, was not resected here on the left side. In this this coil is easy to be seen, and I used a lot of bone graft and biologicals to enhance here the stability with a solid fusion on the right side, because I don't know how long does this patient survive, and I don't know whether the tumor will be destroying the anterior column in the next month. This is a post-op MRI. You can see some seroma because of the huge defect. There was a hematoma and then a seroma, but the patient did well. He received a lot of images, PET scan, and you can see the tumor debulking worked. There was no regrowth here. In the next 2 years, the patient survived 2 years. All the other mets on the spine were present, but didn't do any problems. Lytic, but asymptomatic metastasis in the mid-thoracic, the cervical spine as well, metastasis, but no neurological deficit, no severe pain syndrome here. So renal cell cancer is hard to judge. It's always highly individual strategy. The therapy is sometimes aggressive, sometimes you don't do any surgery when the patient is in bad condition. And this worker was really strong. He was a patient you can take into the OR and do more dangerous surgeries. And I think for 24 months, this is a pretty nice survival time. He was able to walk until the end, and there was a focal control. So my question now is, would you think that debulking has a value, or would you just say, no, the stabilization is the key element of the surgery? And if you have performed only stabilization, which you can do minimal invasive, I would just go to the MIS surgery and not do an open one. So just feel free to criticize me whenever you can and say, oh, open, this was not good. With a minimal invasive one, you could have achieved the same result, because I don't know whether this was a good idea or not. In the end, it helped the patient from the pain, and the local tumor control was there. Leave this poll some seconds longer open. Maybe some is supporting me. This is these are the results of the audience. MIS only is the minority. So these are hard colors, but 25% would have done MIS stabilization only, and 3/4 would have done the same I have done. Maybe I have biased them all. Any questions? So I would go to the next case, which is completely different, because this patient is female and pretty young, 35 years old, and she was presenting with sciatic pain as one, both sides. She told that urine and bowel defecation was not so good, some kind of incontinence. She had some saddle paresthesia, and everything was just with a slow progression. There was no emergency situation, but then finally she came to the emergency room because the family doctor made an MRI, and the MRI showed this, and the radiologist told the patient to go to the hospital immediately. Wendy, do you sometimes tell the patient that they have to go to the emergency room immediately, or do you ask the patient, hey, how are you? How do you feel at the moment? Would you have told this patient the same, that she needs immediately help and advice from a surgeon?
Well, I work in a hospital, so my ER is there, and those are the cases I'm reading. So I wouldn't be in an outpatient center where I would have to tell somebody that. I probably wouldn't. I mean, if they have the symptoms you said, though, even without the imaging, I think they'd want to be in an ER, not in an outpatient imaging center, with the saddle anesthesia and all the things you just described, right?
Yeah, I think you can do two things. You can look at the patient, ask how are you, and if she's fine and only the pain is there and it's slow progression since weeks and months she had these symptoms. I think you can do it like inform the patient you have to go to a specialist in the next days, or you can send them to the emergency room immediately. I think both things are possible, both ways. I will not blame any physician, or what have you done, because this tumor looks really bad. So this is the axial post-contrast. And Wendy, again, highly vascularized, or is this?
It's very unusual. I'm trying to figure out all the places where it's going right here. So, I mean, it looked like, I was trying to see on the other images too. And that's why I was talking, because I was stalling while I was looking. It looked like it was in that distal thecal sac. I can't tell from these pictures on my screen whether, I think it's all extradural and compressing the thecal sac, but that's a kind of a guess because it's also in the posterior musculature as well. So
Yeah.
I think it must be compressing from the back. So bone tumor.
This is T2. This is not hyperintensive, or?
Yeah, so T2 hypointense is a specific category of tumors, usually highly cellular tumors, which are not very many types.
And this is the X-ray, because in some tumors, X-ray gives us very good information. Do you see anything special in L5 or S1 spinous process?
Oh, in the spinous process.
Yes,
No.
in the spinal process, in the tip of the
L5
spinous
looks
process.
pretty good to me. They're not being destroyed, which is interesting considering like something like a renal cell would destroy everything it came in contact with.
Yeah.
So it's a very soft tumor, whatever it is.
You can see here the spinous process of S1 in the middle, and this is the X-ray. Do you expect that this is an aggressive tumor? Can you give your...
I do not, again, because I think you'd see more bone destruction. I was wondering if you were going somewhere with, sometimes you see increased density in lymphoma, but I don't think you could say that on these x-rays, at least on my screen. You can't really tell because of overlying iliac bone and things like that.
And the blood sample, everything was completely normal. So in the peripheral blood, there was no signs of lymphoma. So this was, we did a biopsy, and it was a Ewing sarcoma. And this was an atypical, it's an extraosseous Ewing sarcoma. They made this diagnosis due to immunohistology and genotyping. I'm not so smart, I'm an orthopedic surgeon, but they said it's not a classic Ewing sarcoma, it's an extra osseous Ewing sarcoma. So what is the next step? Just tell me, what do you think, what shall we do with the sarcoma of the spine with incomplete cauda equina compression syndrome? What's the next step? Do we go for en bloc resection? Do we do a marginal resection, a debulking, or do we go and look for a solution with chemotherapy first? And again, you can't do something wrong. You can use the chat box as well. I have a look. What is the chat box saying? Yeah, Michael Young tells us that these Ewing sarcomas are pretty radio sensitive and chemosensitive. And my solution is easy. People told judged for chemotherapy as well, and it indeed is crucial that we do biopsy first, and we can do CAT scan. And now I want to just mention that we do these kind of tumors not as a single surgeon alone. We put these patients on a board, on a tumor board, where radiologists, oncologists, pathologists are coming together, and this is an interdisciplinary decision what we do. Because we were so focused on neurologic deficits, we look for cauda compression syndrome, but we may not forget that there are smarter solutions. And this patient received chemotherapy and radiation first. And what happened to this tumor was really interesting, because with vincristine, efosfamide, etoposide, this VID strategy is so successful that the tumor vanished within 3 months. So you don't see a big tumor mass. You can see enhancement where the tumor bed has been before. You can see here in the X-ray views that the tumor pretty much vanished without any surgery. This is the key therapy, beginning key therapy, and after 6 months you can do everything you want. We did some resection of the spinous process and some paraspinous muscles to look whether there is still tumor left, but there wasn't. So it was just a minimal surgery to have a look whether therapy is successful or not. And after we did this implant-free excision biopsy, the patient received further treatment with proton beam therapy in the center here. And this is the situation 3 years later. And there is still no recurrent tumor. Now, I know this patient since 8 years, and she is still tumor-free. And we have these patients who can be treated by a very aggressive chemotherapy regime with a very aggressive radio-oncology therapy. And I think these images are hard for you, Wendy, because you are asked, is there any tumor left or not? What is happening to the muscles? They are enhanced now, they are taking up contrast. This is not scar, but we don't know what it is. The follow-up always shows a similar situation, no change. And this is so important that you have control in the same radiology department where the radiologist can examine with the images that have been done a year before or 2 years before.
No, that's one key to the muscles that maybe this would help everybody when you're looking at this. The difference between this picture, this is probably a reaction to the treatment, not tumor, but you can see it's not like a mass growing in the muscle like you had originally. You can kind of, I don't know if these are real muscle fibers, but it kind of looks like an enhancing muscle, not a mass in the muscle, which is what you had before. So maybe that would help you distinguish whether you said there was residual recurrent tumor or not.
Yeah. And sometimes it's good to not mention the patient that there is some contrast in the muscles, because they are so focused on these contrasts, and they this is a torture for me because I always have to tell the same phrases without knowing, but in the end, it's tumor-free because this is an aggressive tumor. If there was a remnant tumor inside of these contrast enhancement, it would have grown very fast within the next year. And if there's no recurrence, if there are no change in the muscles, it's a pretty nice situation. Okay, so I was hurrying a little bit through the slides.
Can I ask a question then?
Yes, of course.
I was holding my question so you get through your cases, but I have a question about this one and the last one. For this one, I have never seen a Ewing's turn out this well before. Is it because it was soft tissue only, or if in your experience when they involve the bone as well, can you have such a good result from this regimen? Because we even have protons and I've never seen it do that well before.
I think if you have a look to the studies, Ewing sarcoma, you can have a curation in a higher percentage than in other sarcomas. So from among all these monsters and beasts of sarcoma, the Ewing sarcoma is the one you can cure. So don't be surprised if the patient survives and has a good life quality. In these extraskeletal Ewing sarcomas, this is the only one I have seen. All the others are a lot of younger patients, like 15 to 20 years old, and they are in the chest and the pelvic region. So it is, as always, there are some colibris in your career, and I will always remember these patients. And the most important thing I want to mention is that despite of the chordal compression, despite of this really big tumor, we have to stay calm and ask the smarter guys from oncology and radio oncology what to do first, because she survived with a good result. It would not have been a big mistake if you go into this tumor, debulk it, if you don't put in screws or implants that are not compatible with proton or other radiotherapy regimes. If you just decompress the spinal canal in a Ewing sarcoma like this, I think you're doing it not quite superb and not following the guidelines, but this is not a disaster. This is different to other sarcomas. So you can kill a patient with a sarcoma with a wrong surgery, where an en-bloc resection is mandatory to cure the patient from this malignant disease. But in Ewing sarcoma, the chemotherapy and the radiation is the strong therapy arm, and so it's always nice to have smart colleagues in the tumor board. I learned a lot. When this patient comes now to my hospital, I send them away to the center I've worked in before, because I think these patients have to be pooled in a sarcoma center. We have several here in Switzerland. I think in the US, every hospital is somehow connected to a sarcoma center as well, if there's no sarcoma center in the hospital as well. So Ewing sarcoma is really hard to treat. The chemotherapy is, you lose all your hairs, you get encephalopathic. This is really a severe chemotherapy. You don't wish your enemy to undergo this, but curation in the end is what you receive. So thank you all for listening. I know that Ali Bash told us that next week we have from Mexico Dr. Javier Kilo Olvera, and he will have a talk about spine endoscopy cases. And I just say good night. Here now it's 1 o'clock in the morning, and I say thank you all for listening, and thank you all for interacting. I appreciate all your comments in the chat box, and I wish all you a good night.